education program that is to have a reasonable chance of being effective requires considerably more work and more planning than many people would believe from the materials that are ordinarily presented in textbooks or even in the journal articles themselves. I think, as a matter of fact, there's a marked tendency for many people on reading about behavior modification to conclude that behavior modification is an extraordinarily simple set of procedures that can be carried out by anybody with relatively little planning and certainly very little conceptualization of the problem. I think that one of the critical factors in developing a behavior modification program, and as I said before, this is irrelevant so far as the problem is concerned, and irrelevant so far as the nature of the client is concerned, and that is to have as much information as possible about the client's behavior and, of course, the conditions in which the behavior occurs and the consequences that are provided for that behavior. All of these are very, very critical, and of course one of the things that we find when we are reading a lot of the material that is written about behavior modification is referred to as the ABCs of behavior modification. A standing for antecedent conditions, B for behavior, and C for consequences. I think that probably one of the major difficulties that we encounter in establishing an effective behavior modification program is right at the outset with the behavior that we are concerned about. That I think it is not an unfair statement to state that most people do not know how to observe or describe behavior, as a consequence of which then that we find that very often that when we are talking about behavior, that we are talking about it from a vantage point that makes it very difficult for us to quickly and clearly establish what the behavior is and whether and how the behavior is to be responded to. That we find that very often in our efforts to describe behavior that we take refuge in a lot of descriptive adjectives. And as soon as we get into the realm of descriptive adjectives, we have moved away from a quantitatively and objectively an objective basis for the description of the behavior, and have now introduced a number of qualitative characteristics. I realize that this is very easy to do for the very simple reason that this is the way in which most of us have learned to describe behavior. That is, to utilize a lot of descriptive adjectives to refer to the behavior in question. So that we find, for example, when we're talking about behavior and we use the descriptive adjective aggressive, that here again that we find that we create many difficulties and many problems when we are trying to determine whether or not a particular bit of behavior that we have observed is indeed to be classified as aggressive. Very often you see that when we are making observations that we simply observe the behavior occurring, so that we observe that John hits Bill. And now the problem is, should we call that aggression? Should we call it self-defense? What should we call it? And that if we're not careful, that we find here that a lot of time is going to be spent here in terms of trying to decide whether or not a particular bit of behavior should be called aggressive or whether it should not be called aggressive. I think that that introduces and creates many more problems than it solves. And as a consequence of which, I think that it is critical for us to learn how to describe behavior without taking recourse to these descriptive adjectives. Furthermore, in talking about the behavior, it is absolutely critical for us to ascertain or to describe the the environmental conditions or situations that prevail at that particular point in time. I think that one of the things that is very crucial in all these efforts is to recognize the fundamental point that the organism is always right. By that is simply meant that the organism is doing what the organism has to do given the conditions that prevail. And as a consequence of this, that when we accept that as our guiding principle, then we get away from the view that the individual is doing something in order to, but rather that it would force us, I think, into examining more and more of the kinds of conditions and situations that surround the behavior, the conditions, the environmental conditions, for example, that we can identify as being related to the occurrence of that behavior. So that very often we find here that in setting up a behavior modification program, that our major concern is not with really changing the behavior as such, but with bringing that behavior under the control of environmental events and conditions that we would consider to be more appropriate. That is, if the behavior were occurring in other environmental conditions or in relationship to other environmental events, then we would say that behavior is quite acceptable. But the fact that the behavior is occurring under different circumstances and different conditions would suggest, therefore, then that the behavior is unacceptable. But you've got to bear in mind here that in deciding this, we are deciding it on the basis that not just the behavior, but that the behavior and the conditions in which the behavior is occurring. In the case of the retarded, particularly the institutionalized retarded, that I think that we have to recognize that the kinds of problems that we encounter may be classified in, well, they can be classified in several different ways, I presume, but I think that they can be classified in a manner that would be suggestive of the kind of treatment program that we may ultimately wish to develop. For example, in the case of many institutionalized retarded, we are dealing with a serious behavioral deficit. By a behavioral deficit, we're talking about the fact that this individual has not acquired certain kinds of behaviors, and that consequently then, that in dealing with this kind of individual, our major emphasis then should be on the development of a program that is designed to remove that particular deficit. That would be one kind of problem, and that later on that I shall come back and talk in terms of ways and means by which we would deal with the behavioral deficit. A second kind of problem would perhaps be one in which the problem or the behavior in question would be deemed as satisfactory, let us say, if it occurred at a somewhat lower rate. So that we're saying here that the major problem that we're confronted with is to reduce the frequency of occurrence of the behavior, but we are not interested in eliminating that behavior. A third problem area could be specified as one in which that I referred to earlier, in which the behavior is occurring, but it is occurring in environments that are deemed to be inappropriate. So that we are saying here that if this behavior occurred in different environments, we would consider it to be acceptable. So our problem there then would be to determine whether or not the behavior, whether or not to create a program, shall we say, that is designed to have the behavior occur in those environments which it is deemed appropriate, and to not occur in those environments in which it is considered inappropriate. Here again, I think that as you may already be able to see, that if we acknowledge that as the problem, that our approach to dealing with the problem may be markedly different than if it is a problem that falls within the first two classes of problems that I have described. A fourth possible problem is one in which we find the behavior is occurring, but that the rate at which it is occurring is considered to be too low. And that what we want to do in this particular case is to increase the frequency of occurrence of that particular behavior. Well, these are four classes of problems that we may encounter, and that there would be different kinds of programs that would be developed depending upon the particular kind of problem with which we are dealing. And that under the circumstances then, that it is necessary for us to analyze the situation in order to determine just what is the kind of problem that we are dealing with. I think that very often in behavior modification that we tend to rush in and try to create a program before we have collected enough information, and in order for us to determine just what kind of problem it is that we're dealing with. The particular program should indeed reflect the kind of problem that we're dealing with. Now, one of the problems that always arises in the institutional setting is that very often the emphasis is upon behavior that is more related to the management, to making the management of the patients easier for the staff and the administration. And sometimes we find that these behaviors are not necessarily very significant in the life of the individual patient. And that, of course, is one of the things that can create some problems with respect to the development of a behavior modification program. Namely, that the behaviors in question are more oriented toward the management of the patient than it is for the preparation of the patient to function more effectively. Now, of course, there are times when these two objectives tend to overlap. By that I mean that where increased effectiveness of management would also contribute a great deal to the development of the behaviors that would be very important and critical to the individual. So that we should examine very carefully then what is the objective of our behavior modification program. Is it indeed a program that is designed to benefit the patient, or is it a program that is designed to benefit the management? And that I think that our chances of success are greatly increased when we find that we are concerning ourselves with behaviors that are relevant to the adjustment and the effective functioning of the patient. We have talked about antecedent conditions, we've talked about behavior, and now it is important to talk about consequences. By consequences, I am referring to what happens following the behavior in question. And that here again we're dealing with a problem that in the institutional setting is frequently difficult to deal with, since even in the institutional setting the staff may not have full control over all of the consequences that can be provided to the patient. As a matter of fact, that we have to face up to the fact that many of the consequences that are provided to patients are provided by other patients, and that one of the results then is that despite all of our efforts, we are unable then to affect significant behavioral changes simply because we do not control the consequences. I think that we must face up to the fact that an effective behavior modification program does indeed require that the consequences are controlled by the individuals who are managing the program. It is virtually axiomatic that if the patient can be reinforced, shall we say, by others, or that that there are other people in the environment who are capable of administering punishment or negative reinforcement, and if we can't control that, then of course the control over the program is definitely in jeopardy. That you see that one of the things that is so critical in an effective behavior modification program is this matter of control. Who controls what? And that trying to set up a program for someone in which the manager or the monitor of the program is not going to be able to effectively control many aspects of the environment, particularly the consequences, then our chances of having a successful program are markedly reduced. It is very tough to effectively deal with such a situation. As a matter of fact, that this is a problem that not only confronts behavior modification, but it confronts any other program that is designed to affect change. Sigmund Freud, of course, recognized this very clearly when he was talking about secondary gain. Freud pointed out how people who develop various and sundry symptoms, as he was wont to call them, found that these symptoms gained them a great deal, and that to give up the symptoms, so to speak, without providing some alternative reinforcement for other kinds of behavior is indeed a very tough and difficult task. We encounter this all the time in the outpatient setting, where we find that people are frequently being reinforced for the very behavior that they are complaining about. I have a number of clients right now whom I'm seeing, and that the behavior change process is slowed down tremendously for the very simple reason that we cannot eliminate all of these other consequences that are being provided to maintain the very behavior that the client says that he or she would like to change. Sometimes we find that these consequences are much more subtle than we would ordinarily like them to be. By that I mean that we sometimes can easily overlook some consequences that are playing a very important part in the development as well as the maintenance of the very behavior that is in question. And that, of course, when we come around to talking about the modification of behavior, then we must at the same time face up to the realization that the control of the consequences is essential. As a matter of fact, that one of the things that I routinely do whenever I am dealing with a client is to find out what does the client gain or what does the client avoid by the behavior that is under consideration. I think for us to assume that behavior can be maintained without some kind of consequence being provided, at least occasionally, is an assumption that I consider to be very untenable. At the same time, we must recognize here that just because we make our observations at a particular point in time, and that on the basis of these particular observations, we do not note that any particular consequence is being provided for the behavior, does not necessarily mean that somewhere along the line, that occasionally anyway, that some kind of a consequence is indeed being provided. I think that's one of the most deceptive things about consequences. The realization here that consequences provided on some kind of an intermittent basis tend to be much more powerful in the maintenance of a bit of behavior than a consequence that is being provided all the time. Ordinarily, you see that when a behavior is always followed by a particular consequence, it is relatively easy for us to specify what the consequence is that is maintaining the behavior. But more often than not, the behavior is being maintained by a consequence that is provided on some kind of an intermittent basis. And the result of that, of course, is that at a particular moment in time when we make our observation, we may be completely and totally puzzled because we have not noted that any particular kind of consequence seems to follow the behavior. This is one of the reasons why that over a period of time we are continually getting information that changes and alters our whole idea about the kind of program and the way the program should be carried out than we started with. For example, this of course is an example that is not drawn from a mental retard, but it doesn't make any difference because the same situation will apply to them as to non-retards. I saw a lady who was complaining about certain kinds of behavior that she was emitting. She said she wished she didn't emit those behaviors, and went on and on about how that she gets disgusted with herself, she gets angry with herself because of the things that she is doing. And that I must admit that for a period of time that I was kind of puzzled because she said nothing to indicate that any particular consequence was being provided to maintain these behaviors. And I might add that all of my efforts to make suggestions that would be effective in bringing about change had failed. Well, yesterday, as a matter of fact, she was talking to me, and she was talking about these same behaviors again, and then she was talking about how people would tend to laugh when she would do these things, that she apparently was able to amuse guests very easily by all these things that she said and did. Well, with that, the pieces fell into place, and it became quite apparent how come she was maintaining these behaviors. She was being provided a tremendous amount of reinforcement through for these very behaviors that she was complaining about. I think this situation is much more common than we are inclined to believe. And a lot of times that even though the consequences that are maintaining the behavior are actually very obvious, that we find that we're not, we just seem to gloss over them. I had a lady who had problems dealing with a lot of the activities that were required of her around the house, and that she just simply was unable to deal with these matters. I mean, these are such things as she could not handle. For example, pick up a bottle of household cleaner like ammonia or stuff that you use to wash windows, washing powders, soap, so on. Well, it then turned out, and she told me this right at the outset, and it was the fact that her mother was coming over and was doing many of these things around the house for her. Well, despite the fact that it was very, very obvious that her mother was doing the kinds of things that enabled her to avoid a lot of household chores, I must admit that I glossed over it. However, as we proceeded in the development of a program, it became increasingly apparent to me that, good heavens, that we're going to have to get rid of mother here, so to speak, and we're going to have to introduce some kind of what might be thought of as a response cost system. That is, where I suggested to this lady that instead of having her mother coming over and doing all these things, and of course she didn't pay her mother, that she should have her mother stay at her own home, and that she would go out and hire somebody. Well, to hire somebody to do all the things that her mother was doing would cost her a pretty good bit of money, and that money was not that plentiful. So that under these circumstances, that I was essentially introducing what might be thought of as a response cost component, namely that it was going to cost her to maintain all these avoidance behaviors. I've made this suggestion. I doubt seriously whether or not it will be carried out, simply because the financial conditions are such that they can't afford it. I am quite confident, however, that if we could introduce that response cost component into the program, that her progress would accelerate considerably. But that, of course, is working in the outpatient setting. On the other hand, that in the institutional setting, sometimes it is easier to cope with this problem, providing it involves members of the staff. Unfortunately, the members of the staff are not the only people who can provide these consequences. And it is very difficult for us under these circumstances to go to the patients and talk to them about withholding reinforcement for a particular client or patient. So that it is very, very important for us to recognize here that in the institutional setting that there's nothing automatic to the effect that the reinforcers that you might care to use in a particular program for a particular individual will be under the control of the staff. I mean, you might say, well, but there would be certain things that would automatically fall under the control of the staff. For example, desserts or goodies, these sorts of things, they could be certainly controlled by the members of the staff. Not necessarily, because if you have a patient here who is able to muscle some other patient so that this other patient who has earned these goodies is in essence forced to turn over the goodies to somebody else, then we're going to find that the patient who is able to browbeat or whatever you wish to call it, some other patient to and thereby get the goodie, whatever it may be, not only removes the control of the reinforcer from the staff, but it also winds up reinforcing the patient for a bit of behavior that we may not care to reinforce. So that when you are examining or observing the situation with respect to the potential consequences, look for those that can be provided by other patients. So that though it seems as though the control of the reinforcer should be a very simple matter, It just simply does not work out that way at all. And very often when we find that a program is not working, that a closer observation and analysis of the situation may clearly indicate that a major defect in the program is this lack of control over the consequences. Now, I've mentioned before that many of these consequences are really very, very subtle, and that as a consequence of which it is very easy for us to overlook them. That we also find that there's a tendency for us to consider only those consequences that would be reinforcing for us to be reinforcing for others. That just simply isn't the case at all, and that we can find ourselves in a very difficult position if we tend to discount some of these on the grounds that, well, that wouldn't be reinforcing for me. We also have to recognize that the subtleties of consequences can include such things as head nods and smiles and things of this sort, which we may not easily and readily recognize under the circumstances. Then that it means that we have to very closely observe what is going on in the life of this particular patient if we want to be able to develop a program that has a reasonable chance of being successful. Let us return now to a discussion of the four kinds of problem areas and the kind of program that might be effective in dealing with the particular problem. The first problem area that I mentioned was one of a behavioral deficit. Very often, of course, we find that in the case of the retarded, that the probability of a behavioral deficit is very good. As a matter of fact, that it is very often the behavioral deficits that lead the retarded to be called retarded. And of course, we find that very often it is one of degree rather than kind. By that I mean that every one of us probably has some behavioral deficits. There are many things, of course, that each and every one of us doesn't know. There are many kinds of behaviors that we have not acquired. There are many behavioral sequences in particular that we have not acquired, and under the circumstances that each and every one of us could be said to have behavioral deficits. In the case of the retarded, however, that we find that these behavioral deficits are so extensive in many cases that it makes the individual, or puts the individual, in a very difficult position to cope adequately with his environment. But the same thing can be said probably about many people who have behavioral problems, namely that they have not acquired the kinds of behaviors that would enable them to effectively deal with the environment. But at the same time, I think that we can readily recognize here that in the case of the retardate, that the number or the extent of the behavioral deficits is so great that the individual has a great deal of difficulty coping with problems that arise in everyday living. When these behavioral deficits are extensive enough, then what we find here is that the retarded individual has to be institutionalized. So that in the institutional setting, it means therefore that many of these behavioral deficits are compensated for by the staff. And that so that in large measure, that one of the major objectives of the staff of a school for the retarded is to reduce the level of compensation, so to speak, of the staff members, and set up programs or establish programs that will enable the individual retardate then to acquire the behaviors that would enable the retardate to cope more effectively with the environment. So that this, of course, can pose a problem, because realistically speaking, that many staff members can derive a great deal of reinforcement out of the control that they are able to exercise over the retarded. You may not think about this as a problem, and that, of course, your initial reaction would be to deny it, and that you may very well be right. I'm just speaking generally. Namely, that we find that this situation arises not just in the case of the retarded, but can arise in the case of any individual who has a problem. There are many therapists, for example, whose major approach to dealing with a client is actually to gain control over the client, and to maintain that control, so that to a certain extent then the client becomes increasingly dependent upon the therapist to enable the individual to deal effectively with the environment. I've had clients who would call me about every little problem that would ever arise in their lives, and they'd say, "What do I do? What do I do?" Well, I think that we have to be on guard against this sort of thing. And this is especially true, I think, when we're dealing with the retarded, because they have such a wide range of deficits that the possibility of control that can be exercised by the staff members is so great that it could indeed hamper considerably the development of an effective program for a particular retardate. We must bear in mind at all times that a primary objective of any behavior modification program is to enable the individual to function independently of the behavior modifier. And this is true whether we're dealing with a mental retard or whether we're dealing with an adult who shows no evidence of retardation. Obviously, the level of independence, shall we say, that an MR can attain is going to be considerably less than it would be with somebody who isn't retarded. But at the same time, we want to make sure that our program is as effective as possible in enabling this MR to do as many things on his own as is humanly possible. Obviously, the more we do for somebody, including an MR, the less likely it will be that the individual will be able to do it for himself. Okay, now, given that we have these deficits, how do we proceed to do something about them? There are several different techniques or different procedures that may be used. They may be used independently, or it is entirely possible that we may use a number of these techniques in combination. One rather obvious technique, of course, is shaping. Shaping is a fundamental and basic technique in behavior modification, and it is especially useful in the case of the MR. That the essence of shaping, of course, is to take the individual from where he is to where either he or we want him to go, behaviorally, that is. So that when we are interested in developing a program that involves shaping, it is absolutely essential that we have an adequate measure of where the individual is at the point in time when we are going to start our program. It just simply doesn't make any sense to talk in terms of where we would like the individual to be or where the individual ought to be. The critical question is, where is the individual at this particular point in time when we are going to initiate the program? Consequently, it is essential that we have an adequate baseline. The baseline, of course, is a measure of the behavior or behaviors that we may be interested in. So that in the case of the MR, when we are dealing with a deficit, we want to know something about the kinds of behaviors that are currently being emitted by the individual that may be related to the ultimate behavioral objectives that we have for that particular individual. So that this, of course, can vary considerably from individual to individual. Now, a lot of times one of the hard problems that we are confronted with is trying to determine what it is that the individual is doing at this point in time that may be related to the ultimate behavioral target that we establish. A lot of times we are not readily able to make this kind of determination. Yet it is going to be essential if our shaping procedures are going to be effective. It doesn't do us much good to start off with behaviors that are unrelated to the ultimate target behavior if the initial behaviors that are currently being emitted are unrelated to this final behavioral objective. Now, once we have established what behaviors the individual is now emitting that may be related to the ultimate behavioral objective, then it becomes possible for us to try to establish the particular behavioral steps that will in between where the individual is and where we want him to go behaviorally. Now, this, of course, is not an easy thing to do. We're always confronted with the problem of how big should these various steps be. And frankly, there is no nice, neat formula that tells us either how large the steps should be or how many steps there should be from where the individual is to where the individual is to go. I think the prevailing rule of thumb that I tend to rely on is that it is much better to make the steps small and, if anything, have too many steps than to have too few steps. The obvious consequence of having steps that are too large is that the individual will have a great deal of difficulty going from one step to the next step. So that in setting up the steps from the current or the present emitted behavior to the ultimately to be emitted behavior, we should look at it from the standpoint of erring on the side of too many steps. If we have the steps are too small, that all that it means is that we'll be able to move through them a little more rapidly. And in the case of steps that are too large, we may discover that the program gets hung up, the individual becomes disenchanted or quits, and the shaper also finds that this can become very discouraging. If, of course, it turns out that you have made the steps too large, rather than battling it out along this line forevermore, a much better alternative is to say, okay, let's put in some more steps. To err in this matter is not a horrible crime. There's certainly nothing wrong with it, because everybody must recognize that regardless of how skilled we may be and how much experience we may have, we are still, to a large extent, flying by the seat of our pants. And of course, there's always the possibility here that we're going to put in steps that turn out or may not, on closer inspection, be related to the final behavior that we're interested in. One way in which we can perhaps minimize this is to proceed from the terminal behavior back to the currently emitted behavior. In other words, we establish our steps in a backward fashion. I think that by doing this, it enables us to see more clearly the relationship between each step and the succeeding step. and thereby minimize the likelihood that we are going to put in steps that are in the final analysis unrelated to the terminal behavior. Once we have established our steps, the next thing that we should do is to make sure that we have an effective reinforcer. Well, this of course too can be a very serious problem. There are some rules of thumb that we find that have been developed over the years. Some of these rules of thumb are empirically based, and some of them are more or less clinically based, or based upon some observations, frequently not too systematic. One thing that I found that very helpful in many instances is to utilize the Premack principle. And the Premack principle, simply stated, is that a high probability behavior can serve as a reinforcer for a low probability behavior. If in the course of making our observations of the individual, we have observed that in an unstructured situation that the individual intends to engage in one activity a great deal more than any other activity, then that activity in which the individual engages considerably can serve as a reinforcer for other behaviors that are occurring at a lower rate, or perhaps are not occurring at all. So that, for example, if TV watching is a high probability event on the part of a child, and doing homework is a low probability event, then of course that making TV watching contingent on doing homework will be an effective way to utilize TV watching as a reinforcer. So that this is one way in which we can get a handle on what would be a reinforcer. Another way is one that evolves from what is called equilibrium theory, and that in equilibrium theory, that a low probability event can serve as a reinforcer for a higher probability event, providing the lower probability event is occurring below its operant rate. So, for example, a child who is permitted to go to the movies once a month, therefore making it a low probability event, that it could be used as a reinforcer for some other behavior that may even have a higher probability of occurring. And in this way, then, that we may find that we're dealing with a situation that is akin to deprivation. And deprivation, of course, is another way in which it is possible for us to establish something as an effective reinforcer. So that if we deprive an individual of some activity, even an activity that has a low rate of occurrence, then we are going to increase the likelihood that being able to engage in that activity will indeed serve as a reinforcer for other kinds of behaviors. In many instances, of course, we can simply ask the individual what sorts of things they like or what kinds of activities they like to engage in. In the case of the retarded, particularly the severely retarded, we may have a great deal more difficulty doing that. So that it is essential that we get a handle on what constitutes an effective reinforcer before we can hope to have our shaping process proceed in a normal, in an effective manner. Now, a lot of times then, I think, speaking realistically, that we have to go on a trial and error basis. That is, we try something and we find out whether or not it works. If it works, fine. we then continue. If it doesn't work, then we look around and see if we can't find something else that will work. But let us assume now that we have gotten our hands on an effective reinforcer. Preferably, we have gotten our hands on several effective reinforcers. Now, the shaping process, of course, means that we have established the steps that we wish to pursue, and that it means, therefore, then that we will start out perhaps reinforcing the individual for the behavior that he is currently emitting. We do not reinforce too many times here, because if we do reinforce too often at any of the behavioral steps along the way, there is a very good chance then that the individual is going to hang up on that step, because with repeated and continuous reinforcement of a given bit of behavior, we increase the probability of stereotyping. As a consequence of which, then, the probability that the individual will emit a behavior that is a closer and closer approximation to the next step is greatly reduced. As a matter of fact, it is variability in the behavior that is being reinforced that is very, very critical to being able to move the individual along the way to the ultimate terminal behavior. So that we might reinforce the individual 2 or 3 times for emitting that behavior that he is currently emitting. Then we withhold reinforcement for that behavior, and now we'll reinforce the individual for the next behavioral step. Again, here we would reinforce only a few times, and then we would discontinue reinforcing for that particular step and require the individual to emit the behavior that comprises the next step in this whole sequence. So that you can readily see then the importance of having the steps rather small in order to increase the likelihood that the behavior will occur at all. And if we do follow these procedures, that gradually we are changing the individual from where he was to where we want him to be. Granted that it sounds like the shaping process is a very long and time-consuming one. Actually, if we have set up our shaping program very effectively, the probability is that we can move someone along at a fairly rapid rate. Because again, that we're not going to be providing a large number of reinforcements at any particular step along the way. So shaping is one way in which we can perhaps deal with a behavioral deficit. Another way that is sometimes effective is modeling or imitating. Here again, we have a good bit of evidence that has been generated by Bandura and his associates to show that there is an increased likelihood that observers will tend to model the behavior of someone who is reinforced for that particular behavior. So that here again, we sometimes find that it would be to our advantage to be able to use another retard as the model, if that is possible. So the available evidence suggests anyway that the closer the model is to the target child in age and other characteristics, the better the chances are that the target child will indeed then imitate the model. Of course, it's very important that the model is reinforced for emitting the behavior that you want the target child to model. And accordingly, if the target child then imitates the behavior of the model, then the target child should also be reinforced. In addition to modeling, another possibility is the use of guidance. Guidance, of course, as a vehicle for having an individual acquire a behavior tends to be limited in large measure to physical motor activity, in the sense that in the case of guidance, that we actually guide the individual through the bit of behavior that we wish him to acquire. So that if we're interested in having a child learn to write his name, that we would actually take his hand and guide it through the production of his name. Guidance is and has been used quite extensively in a number of different settings, and again, it is something that it is a technique that has some utility if it is used properly. Well, these are the three most effective ways of working with a behavioral deficit, in that there are other techniques for working with deficits, but other techniques would not be as applicable to the retarded individual as the techniques that I've just described. Obviously, if we have a retarded child who has a fair command of verbal behavior, that it may be possible for us to utilize verbal instructions as a vehicle to developing behavior. But again, that I think that we have to recognize that in the case of many retarded, particularly institutionalized retarded, that it is going to be highly unlikely that we will encounter very many individuals who will have the verbal behavior that inadequate amounts to effectively utilize instructions. But if that situation should exist, then it is possible for us to utilize instructions. Of course, we have to bear in mind here that when we are utilizing instructions, that we have to acknowledge or recognize that instructions simply are verbal behaviors, and that their effectiveness depends upon whether or not these verbal behaviors have indeed acquired the kind of control over the necessary behaviors for them to be effective. This is why I doubt very seriously whether or not instructions is a viable method of dealing with deficits in retarded individuals, particularly institutionalized retarded.